am recording. Everything is good to go. And we're going to pick up the speed a little bit. So be prepared to just kind of blow through some of this stuff. In your textbook, there are good pictures that start on these different blood flow issues and cardiac issues, and it gives a good outline for this. If you're still having troubles, let me know, and I'll see what I can do to help you understand it a little bit better. But recognize a lot of it has to do with, and it talks about, when you go through, where the blood flow is, okay? Where is it shunting from? Where is it shunting to? Are we increasing pulmonary blood flow? Are we decreasing pulmonary blood flow? Is there obstruction that's keeping the blood flow from going to the body and keeping it in the heart or from the heart? Mixed blood flow means that it's oxygenated and deoxygenated blood mixing together. Sometimes they're classified as cyanotic or acyanotic, which means they're either blue babies or they're not, okay? It can also be related to the contractility state, where it's working, where it's not. But a lot of it relates to the oxygenation of the blood. Where is the blood shunting to? Is it going to the lungs or not going to the lungs? Do we have oxygenated blood getting to the body or do we not? Okay. If we don't have oxygenated blood getting to the body, the baby's going to be blue. Okay. That's your cyanotic conditions. The baby's blue. Sometimes we have mixed blood getting to the body, which means after some endurance or some feeding or some activity, then they get blue because they don't have enough oxygenated blood getting to their body. So mixed blood has activity intolerance and more blue coming at that point, okay? So we'll be looking at that, and treatment really varies according to what's going on and the defect, okay? So the increased pulmonary blood flow defects. So these are the ones that increase blood flow to the lungs. It's an abnormal connection between two sides of the heart, and it increases blood flow to the lungs. It decreases blood flow to the body. So when we think about an atrial septal defect, this is a hole between the atrium, and it pushes blood flow from the right atrium into the left, which then causes more blood flow to go to the lungs. Ventricle septal defect, same thing, hole between the ventricles. So it's pushing more blood flow to the left ventricle, which then can cause backup into the atrium, which causes more blood flow into the lungs. Atrioventricle canal defect is where we see holes in both. And a patent ductus arteriosus, where's that ductus arteriosus? Remember? At the top, right? And that, because the aorta has a lot of pressure in it as it's pushing blood to the body, it actually pushes more blood into that left atrium, which increases blood flow to the lungs again. Right? Make sense? So, atrial septal defect. So it's a simple defect of the atrium. It's a hole between the atrium. Okay. We may have some issues with our heartbeat with the sinus venous defect, but we look, and this is just simply labeling, guys. It's just labeling, and you don't really need to know it. Just know that there are different labels by how big it is and whether it's on the top of the atrium, the bottom of the atrium, that kind of thing. But know the general idea behind an atrial septal defect. You have a murmur. You have a right ventricle heave or thrill. If you put your hand on a very small baby, you'll feel that right side of the heart will have a little thrill to it. It'll be, you'll feel it, it'll feel different. Right atrial enlargement, right ventricular enlargement. There'll be a second heart sound. And then it will lead to signs and symptoms of cardiac failure. We look at it through signs and symptoms. It may be asymptomatic. A lot of times with ASDs, they close automatically within the body. They do a lot of times will close, but not always. Okay, depends on the size of the hole or the defect. They may develop heart failure. A lot of times when they're older. Excuse me. We had a faculty member that worked here, and she had a VSD and never knew it until she was in her 50s. And then it was huge, and ended up having to have heart surgery to repair it. So, because that's when it started affecting her. And sometimes this will be the same thing. Pregnant women, a lot of times is when we diagnose ASDs and VSDs in pregnant women because of the increased blood flow to the heart from the pregnancy. And so that's when some of this stuff becomes evident. But they do have the characteristic murmur. They may have some atrial dysrhythmia, the AFib, that kind of thing. They also may get some COPD as they get older in life, and an increase in risk for emboli. All of that's found on page 978 in your text. Okay, guys? Box 27-4 goes through 978, or 978, 79, 80, 81, 82, 83, and 84. And it gives you an outline of all these different defects, okay? 27-4. Box 27-4 starts on page 978. We do an echocardiogram to diagnose this, as well as a heart cath. And then we also will do a chest x-ray and an ECG to make sure that we're not having any complications that way. Again, it may spontaneously close over the first year of life. They may have to go in and close it with surgery. It just depends on how severe it is. We're going to monitor for complications of heart failure, which we know what that looks like already, right? And then post-op care for if it's a cardiac cath that they've done repair, if it's a cardiac window, that's a very small opening in the chest versus an open heart type of procedure. Typically, with ASDs, repair is done through a heart cath or cardiac catheterization, or pericardial window, a very small opening. Does not usually take open heart surgery for that. Ventral septal defect, again, it's a hole between the right and left ventricle. It's the most common congenital heart defect. It's also one of the mildest. Don't have as much complication with it. Like I said, sometimes they don't ever know they even have it. It can be located anywhere in the ventral septal wall, and it can be anything from a pinhole all the way to like Swiss cheese, where there's holes all throughout that the ventricle septal wall. All of that can be just riddled with holes. They call it Swiss cheese, VSD. Signs and symptoms generally are asymptomatic. They may show some signs of right ventricular heart failure, and they may have a murmur. Heart failure is common. It's usually what it leads to. They don't have any symptoms until they have heart failure, kind of thing, unless it's bad. If it's the Swiss cheese and there's a lot of mixing of blood and a lot of issues, then that can cause. The worse it is, of course, the more symptomatic they're going to be. They have an audible murmur. Again, if we're listening, we want to make sure that we know where to listen to that and expect to see it. We'll look at a chest x-ray for cardiac enlargement. We'll do ECG to see if there's changes, because again, recognize if the junky fibers and all of those things are down in that ventricle septal wall. And so if that's Swiss cheese, then their heartbeat isn't going to, the electrical conductivity is not going to work like it needs to. echocardiogram, heart cath, MRI for confirmation. Okay.
So with like the murmurs, does it just depend, so I know it depends on where it actually is. For like a atrial septal defect, would it be more into the, right atrium or left atrium? And then with like the ventricular septal defect, would it be like the left ventricle or the right?
And typically for these, for the atrial septal and the ventral septal, you're gonna hear them on your right side. Okay? So you're gonna hear that on your all and take. More on your right side than your left. And those in the muscular septum usually close spontaneously, but then they may suffer from the right ventricular overload. Those are typically repaired surgically if it's large. They will go in again through heart cath or pericardial window, small, not open heart type of thing. Transcatheter closure device is usually what's used these days. So we do education on heart cath and those types of things. Atrioventricular canal defect. Okay, this is, like it says, it's known as an ABC or endocardial cushion defect. It's a combination of the ASD and the VSD. Okay, it involves the valves. It's often seen in children with Down syndrome. And you have the left to right shunting of blood. So it's from the left side of the heart to the right. Everything kind of pushes over. There's no cyanosis. It's again going to be one of those that you see your activity intolerance and those types of things. And there's a lot of variations to it. So going into detail of what that actually looks like, because there's so many variations, just know that it's a combination of the heart is basically left to right shunting, so it's pushing blood from the left side of the heart, the oxygenated blood, over into the right side of the heart, which then causes pulmonary congestion, okay, ultimately. But you're not gonna see the cyanosis because it's mixed blood, okay? So they'll have the shortness of breath, the respiratory distress. This one, look, you see periorbital edema. Look for these things that make them a little bit different than the others. When you're trying to figure out how do you know the difference between these, look for little things like this with the periorbital edema and ACV. That's going to, you didn't see that in the other two, right? You're seeing it now. Again, increase in respiratory infections, that's that left to right shunting, and more blood flow causes more fluid in the lungs, which increases the risk for pneumonia, bronchitis, increased blood flow, increased secretions, increased respiratory infections. Physical exam, listen for the murmur, chest x-ray, ECG support. Again, same thing, looking for enlargement of the heart, looking for changes in the electrical conductivity of the heart. Echocardiogram, heart cath, MRI is the one that confirms what's going on. So this is more complex than just a simple ASD or VSD. I should say VSD, not ASD and ASD, it should be VSD. So prior to surgery, we want to optimize cardiac output. It's really important that we get that cardiac output as good as possible before surgery so that their outcome is good. We want to make sure that they're gaining weight and they're not having the failure to thrive, or they don't have enough nutrients and adequate weight gain and adequate supplies to help them heal after surgery. Okay, you don't want to take a weakened child into heart surgery because they can't recover. Okay, so we need to make sure that that cardiac output is as good as it can be before surgery. They're at the best nutrient level for them. That may cause some supplementation. You may have to have supplementation, you may have to have tube feedings, you may have to whatever. Because if they're having trouble sucking because it's too much work, then dropping an NG tube or an OG tube is really important to get them the nutrients that they need so that they can gain weight, so they can be healthy and have the nutrients of stores for after surgery to recover. Okay? Post-op care, again, what type of surgery are we having? What are we doing? If it's cardiac cath, we know what to do for that. If it's open heart surgery or pericardial window, think about those things and what are you watching for, and recognize that a lot of education, again, revolves around what? What's our main complication? What is it? Say it again?
Heart failure.
Heart failure, woohoo, good job. All right, patent ductus arteriosus. This is the simplest form of a vessel defect. 8 to 10% of newborns have a PDA that remains open. It can take up to a year to completely close, and it can occur alone or in combination with a coarctation of the aorta. Patent ductus arteriosus, again, is that hole that runs from the aorta into the left atrium. The pressure that's in the aorta is so strong that it has a tendency to keep those holes open until the body can effectively close it, which takes time for it to grow and get stronger and that kind of thing. So, on this one, your signs and symptoms, the main one is the murmur that's machine-like. This is your machine-like murmur. It's heard at the left subclavicular margin, okay? So, left subclavicular margin, so think about where that's going to be. They'll have frequent colds. They have fatigue, poor feeding, poor growth pattern, and a widened pulse pressure. What does a widened pulse pressure look like? What does that mean? Right, so it's a large gap. So their systolic will be slightly elevated, but their diastolic will be low. Okay, so you look for that widened pulse pressure, and you know that there is a risk for a PDA. We got a widened pulse pressure, their frequent colds, machine-like murmur, those types of things, you're looking at a PDA. All right. So the diagnosis is looking for those signs and symptoms. The chest X-ray and an echocardiogram will also confirm the PDA. So we can give indomethacin, which is a medication. We can give indomethacin, which will cause that to close, cause it to close. If there seems to be an issue, if it's not closing on its own, then a lot of times they'll try the indomethacin. But a lot of times within that first year, it will close on its own. We only do surgical intervention if it's absolutely necessary and we're seeing signs of heart failure and we're seeing signs of the frequent colds, and that is affecting their ability to grow and feed and do those things. And it is done through a catheter, so it's going to be your heart cath. And so our education and discharge instructions revolve around that. Any questions? That kind of takes care of your decreased or increased pulmonary blood flow defects. Okay. Okay, now we're starting obstructive defects. This starts on page 980 in your textbook. Page 980. So obstructive defects. So this is basically where there is an obstruction within the heart somewhere that causes an issue within the heart itself. So let's see where these obstructions are and what they do. Okay, so the first one is coarctation of the aorta. Then we have valvular aortic stenosis and pulmonary stenosis. Okay, those are your obstructive lesions. They obstruct blood flow somewhere. So with coarctation of the aorta, basically we have a narrowing of the aorta, which decreases blood flow to the decreasing aorta to the distal carotid arteries and different areas. Depending on where that coarctation is, will determine what it's actually affecting. But basically, it's a narrowing within the aorta. So you're not getting adequate blood flow to the extremities, to the head, to anywhere in the body. Kind of staying in the heart. They have low blood pressure, but high blood pressure. Okay, so if we were to put in a monitor that monitors the blood pressure within the heart itself, it would be high, right? But anywhere else outside the extremities, the blood pressure is going to be low. That's what that's saying. High blood pressure before the point of coarctation, but low past the point. The blood flow to your extremities will be limited. Okay? It's a narrowing or stricture of the descending aorta distal to the carotid arteries. The location can be preductal, ductal, or postductal, and that determines the classification. So where is it at? GP in the legs is typically higher or equal to that in the arms. If they're hypertensive in the arms and weak in the legs, okay, so it's normal if we're doing blood pressure of all the extremities for blood pressure in the legs to be slightly higher or the same as what's in the arms, okay? That's normal. If we have higher blood pressure in the arms than we do in the legs, then we're looking at a coarctation of the aorta. So if you have a higher blood pressure or hypertensive in their arms and lower blood pressure in the legs, expect coarctation of the aorta. So because of that, they're going to have pain in their legs because they're not getting adequate blood flow to their legs. You know how you work out and all of that, and then your legs get achy right after because it doesn't have enough blood flow? Well, they feel that way all the time. And there's not really, the only thing that's going to help them is to repair that stricture, right? So, telling them, you know, to drink pickle juice or whatever, it's not that type of aching, you know? It comes from the lack of blood flow to their legs. So educating parents when the kid says, it hurts me, my legs hurt when I run or play, you know, letting the parents know that that's going to be part of the disease process is important for understanding. And the child too, you know, until we get this fixed, this is what's going to happen and what, you know. And this may be something that you may not see until a little bit later, depending on the severity of it. How heavy is that stricture? Big, heavy, whatever it is I'm trying to say. You will hear a murmur, and it will lead to heart failure, right? Because blood isn't getting out to the body. It's a stricture. So all the blood is staying in the heart. So it leads to heart failure, right and left, because it's all going to back up. Initially, it'll start with left-sided heart failure and then lead to right-side heart failure as it progresses. Again, your diagnosis comes from the difference in the blood pressure, and probably also with that's usually your first indication, or your first diagnosis comes from that, but then I imagine an echocardiogram will also illustrate that as well. And you may also see enlargement through a chest x-ray, your MRI, those types of things as well. So we want to make sure that we are taking the blood pressure appropriately. We know how to take a blood pressure and where to take a blood pressure in the arms and legs, and so that we're getting good readings. If you don't know how to take a blood pressure in a leg, or where you listen to the heartbeat or whatever, then I would suggest you look that up and be familiar with how to appropriately take blood pressure in the arms and legs. The first thing they'll try is the angioplasty, where they put a balloon in And they enlarge the balloon in the area of the stricture, trying to open that up and get it to take, to allow that to stretch and open it up. They will try that first. It may return. If it returns, then they may try a stent. They'll go in and put a stent in to hold it open, okay? So it's important though that we recognize that because the body is not used to having adequate blood flow to the extremities, we can have some severe hypertension that comes after that when that blood is released into the body. We can have a lot of issues because the heart's so used to working and pumping so hard against that stricture that suddenly we've got this huge blood pressure because it's free, okay? So we have to be watching for that hypertension post-operatively. We're gonna give antihypertensive medications for about 6 months to possibly a year, depending on how long they have symptoms. The main ones we go to are captopril and enalapril. What kind of medication is a pril? You know? Who knows what a pril is?
Cholesterol.
It's not a beta blocker, is it?
Nope, beta blockers all
The
over.
The R.
ACE inhibitor.
Very good, it's an ACE inhibitor. So I would be familiar with those medications, I do believe they're on your blueprint. And then we have to watch because it can come back. As they grow, as they get older, we may have some restenosis, so we may have to go in, and this may be something they have to do frequently throughout their life. Open that back up, put another stent in, whatever the case may be. And monitoring and educating and teaching the parents to watch for heart failure and symptoms of heart failure, because that's what's gonna illustrate we've got another problem coming. So make sure that they know that. Valvular aortic stenosis is a malformation and narrowing in the aorta, around the aortic valve. So again, we have issues with the left ventricle having to work harder to get the blood flow out and into the body. So this is an aortic valve stenosis, so that means it's a hardening of that aortic valve so it doesn't give and open like it's supposed to. The little leaks in it are hard and they don't open and give, so that holds it into the heart. It leads to hypertrophy, which hypertrophy is that enlargement in the muscle, right, and heart failure. It's working really hard, so that muscle's getting thicker and thicker and not giving, and then it gets stretched out and it just turns into a big mess. This can be caused after birth due to disease processes. So if we get about something that causes stenosis on our valves, then we can have the valvular aortic stenosis that can be acquired after birth. We have an audible murmur during the systolic phase. And there may also be a click and a thrill. You may hear a click on that as well. They will have chest pain, fatigue, syncope upon exertion, and then they'll also have some heart failure in the neonates. We look at clinical findings. We're going to listen for that murmur, that click, that thrill. We're going to do an echocardiogram, a chest x-ray. We're going to look at EKG to see if there's some issues with their rhythm. And it will show that left ventricular hypertrophy in the echocardiogram and their ECG. The cardiac cath is the only definitive test that says 100%. You'll see some of it in the echo, but with the cardiac cath, that's what is definitive. And it will measure the exact gradient of pressure that the heart has to work against, and then exactly how hard the heart is pumping. That's done in a cardiac cath. So this valve is a high flow, high pressure area, and so it's really important that we get it fixed, okay? We may give medication to help initially. We're gonna do the balloon angioplasty. We may have to change the valve out and put in a new valve. This is valvuloplasty. Or we may repair or replace the valves as well. So we may fix it, we may stretch it, or we may replace it altogether. It requires lifelong monitoring. Valves are only your pig valve, your Mechanical valves that we put in are only good for so long, and they have to be changed out and repaired frequently. So again, this is another, just like with the other stenosis, this is another lifelong measurement that we have to be constantly monitoring for. And also, again, teaching signs of heart failure, teaching what it looks like if it happens again or they start to have troubles. They need to know what this looks like so that for the rest of their life, they are monitoring it. It's not something that goes away. So we want to make sure our education and our discharge instructions, we want to make sure we're teaching about the blood pressure medications and the side effects of those and what we're looking for. So make sure you're familiar with those and side effects and all of that, that we teach them for that particular medication. Pulmonic stenosis, this is a malformation of the pulmonary valve or the pulmonary artery, okay? So if we think about the blood flow to the lungs, there's something in that. So from your left atrium going into your lungs, there's an issue there, an obstruction there, or the pulmonary artery itself has some constriction in it. It leads to heart failure symptoms, including, so this is gonna lead to a backup in the right side of the heart, right? And so then you have your liver enlargement, your hepatomegaly, that's liver enlargement. It's associated with the Noonan syndrome. Look it up. Not on this test. Just a second. It can also be a part of the tetralogy of Fallot, which we're going to talk about in a minute. And that's another, or actually we may talk about it next week. I don't know yet, depends on how far we get. That's another tetralogy of Fallot is 4 different issues within the makeup of the heart. And one of those is pulmonic stenosis of the tetralogy, the 4 different defects. It can be congenitally malformed or physically altered because of disease. Again, this is something that calls valvular disease. So your rheumatic fever, your Kawasaki disease, those types of things, your endocarditis that affect your valves, can cause the pulmonic stenosis. Or it can be congenitally, which means at birth. So we're gonna have a murmur. When their blood pressure is up, they're gonna have a lot of dyspnea, they will have trouble breathing. They're not getting blood flow to their oxygen, to their lungs, blood flow to their oxygen. They're not getting blood flow to their lungs. They may have moments of cyanosis during periods of activity. It's confirmed by a murmur, the echocardiogram, and then the ECG is going to illustrate some right ventricular hypertrophy. Because the right side of the heart is trying to pump really hard to get that blood flow into the lungs. So it's getting larger because it's not able to push it into the lungs. The cardiac cath is going to illustrate the degree of the stenosis, again, measure that pressure gradient, and be able to say exactly how severe it is. So we want to make sure we're keeping the blood pressure down. We want to observe closely and decide how severe it is before we intervene. And then we're going to do the balloon angioplasty, the valvuloplasty, and it may lead to open heart surgery depending on the severity of it. Okay. This is another one of those that we have to monitor lifelong for restenosis. And also educate and give discharge instructions appropriately for lifelong education and repair and after surgery, what are we doing, and all that stuff. Everybody doing okay so far? Hanging with me. All right, good. Now, these are defects with decreased pulmonary blood flow. You have the tetralogy of Fallot and the tricuspid atresia. This is a little picture that helps to kind of think about what's going on. It's not great for me, but it might be great for you if you're a visual person. For me, it's just there. But the heart kind of takes on a boot-like shape. due to enlargement of the left ventricle and kind of the way it ends up looking. You have pulmonary stenosis, so remember it's one of the four. So pulmonary stenosis, so blood flow is not getting to the lungs. Right ventricular hypertrophy, so the right ventricle is getting big and large. You'll have a ventricle septal defect, so you have a hole between your ventricles. And then you have an overriding aorta, or a displacement of the aorta over the ventral septal defect. So the aorta just kind of comes in and connects in an odd place, not where it's supposed to, which then causes an issue with blood flow to the body. Okay, so that's what that means by an overriding aorta. It doesn't go and connect where it needs to, it's displaced. So it's a combination. There are four associated defects with it. The ventral septal defect, the overriding aorta or displaced aorta, hypertrophic right ventricular, so the right ventricle is getting large, and then pulmonary stenosis, so lack of blood flow to the heart. To the lungs. So if you think about it, everything is kind of pushing, and it's just not a good thing. They can go years without seeing this. But a lot of advanced technology, they're actually at a point now where they can start to see it in utero when they're doing the ultrasounds of your babies before they're born. They're actually at the 32-week one where they do the 32-week ultrasound. They're looking at the four chambers of the heart. They're looking for this pulmonary stenosis, the overriding aorta, the enlargement in the right ventricle. They're looking for that. When they start looking at the heart at 16 weeks, all throughout the pregnancy, they're looking for these potential malformations so that they can help these newborns when they're born. So that's what it means by advanced technology and early screening. They see that. So some of the signs and symptoms are going to be tachycardia, dyspnea on exertion. You're going to have some failure to thrive. Now, once that PDA closes, they're going to have a lot of cyanosis. Okay, so if that PDA is open, it's keeping that mixed blood and it's helping to get some oxygenated blood out to the body because it's open and some of that is getting out. But if it closes, then we have some issues. There'll be a loud systolic ejection murmur. It's very harsh and radiating. And then also the right ventricular hypertrophy or enlargement. It's found through clinical findings, your ECG, your echocardiogram, and your heart cath. Another thing that they talk about in tetralogy of Fallot is that kids will have what they call TET spells. Okay. What those look like is they'll be out playing and they'll start to get cyanotic, and they know from instinct that if they squat, it helps to bring that blood flow back to their heart and keep it and not have that resistance of their body, and they recover quicker. So one of the questions with screening that we'll do is if they see cyanosis, does your child squat? Okay. Do they bring their knees to their chest? Then we know that they're having what they call TET spells, where they get cyanotic, they squat, they bring their knees to their chest, they recover. Okay? So that's a question that we'll ask a lot of times, looking for that clinical findings for tetralogy of Fallot. So we want to prevent or monitor symptoms that are associated with it. We'll do surgical treatment to repair it, and then post-op care, education and discharge instructions. And then tetralogy of Fallot is found in box 27.6, page 981. Box 27.6, page 981. Most of these different heart issues, because of technology today, our prognosis is typically good. with just a few that have a very poor prognosis, okay? Because we can surgically repair them, we can address them through heart caths and minimally invasive procedures, the prognosis is typically good. And education. Your well-educated patients are gonna do better than those that aren't educated or don't understand or don't heed education, right? Okay. Next is tricuspid atresia. This is caused by an error in the formation of the tricuspid valve. It is incompatible with life. No blood flow from the right atrium reaches the right ventricle. Most children born with this also have septal defects such as the ASD, the VSD, and the PDA. Now that I said that most of these are, prognosis is good, here comes one that's not. Basically, if you look at this is kind of what it looks like with tricuspid atresia. You have unoxygenated blood coming into the body, or into the heart, from the upper and lower body, okay? But then it doesn't go anywhere. There's no valve that puts it into the right ventricle. Instead, there's holes. Holes that separate it from the left side of the heart, right? Holes that cause the left side of the heart to push more blood flow in to that right side where it doesn't have anywhere to go. So the blue blood has trouble. It doesn't get into the right ventricle, or it has trouble getting into the right ventricle. So very little blood then goes to the lungs, right? Because the right ventricle pushes it into the lungs. There's very little blood flow that gets into the lungs. So we have issues with that. Blue and red blood being pumped into all parts of the body instead of just red or oxygenated blood. Blue and red blood, so mixed blood is going to the lungs. We may have some issues with the pulmonary artery being blocked, but a lot of issues just from mixed blood. And then there's holes everywhere as well sometimes with this. So signs and symptoms, this is going to be your blue baby, okay? They'll be tachycardic, dyspneic, not be able to breathe, and they'll be blue. There'll be a murmur in the left sternal border. This can be discovered in ultrasound, okay? It's also found at signs and symptoms when you have a blue baby. They can't get it to come around. We're going to want to maintain your PDA at this point, keep that mixed blood, as much mixed blood as we can going systolic or systematic through the body. They'll do an echocardiogram, a chest x-ray, cardiac cath, all of those things to review and see if they can figure out what's going on. Emergency intervention. Again, prostaglandins are given to keep that PDA open. They'll do the balloon, they may have to do more, it just depends on, the Glenn and the Fontan procedures are procedures where they actually go into the heart and create the valves and those types of things. Just need to know that those two procedures address tricuspid atresia. I'm not gonna ask you specific information about those, okay, so don't get crazy on it, knowing what that is. And again, because we're doing open heart surgery, we're going to be looking at education and discharge instructions for this as well. All right, any questions at this point? How are we doing? Okay? Kind of? Mixed defects. Your mixed defects are going to be your transposition of the great arteries or transposition to the great vessels, basically the same, that's the same thing, just names. Total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart syndrome. I do not want to say that 5 times fast. Just any of that. Just saying. All right, so transposition of the great vessels is exactly what it says it is. It's when the aorta and the pulmonary arteries do not connect in the right places. They actually are transposed. So instead of the aorta coming from the left side of the heart, it's actually connected to the right side of the heart. And the pulmonary artery, instead of being connected to the right side of the heart, is connected to the left side of the heart. So as you can imagine, we have issues. Things are not going where they're supposed to go. Blood is not hitting to where it needs to go. Because blood's coming into the right ventricle and then it's being shot out to the body, which means nothing oxygenated is getting to the body, right? Your pulmonary blood flow is coming from your left, which is only getting blood flow if we have some type of hole, some type of defect getting blood flow to that part of the heart, okay? So, this occurs in utero. It can be a twisting. Typically, the way the body is formed is there is a twisting. There is a twisting of that causes those vessels to grow where they need to grow, okay? But instead, there's a division, and it doesn't grow like it's supposed to. It doesn't form like it's supposed to. So they're going to be blue babies. Shortness of breath, poor feeding, rubbing of the fingers and toes, and they may have a murmur. We're going to look for clinical findings. We're going to see that cyanosis. Pulse oximetry will be helpful in diagnosing this because they're not getting enough oxygenated blood into their tissues. The ECG may show some issues within their heart, echocardiogram, and a lot of times, again, the fetal echo, the one they do in utero, will pick this up. They'll see some of the issues with this, making sure that everything's where it's supposed to be. So again, that ultrasound. These are issues that sometimes with your women that don't receive health care during pregnancy, you can have a blue baby and not know why, if they haven't had that ultrasound. And that's when things get deadly, okay? That's one of the reasons why we stress getting ultrasounds when at those times when we tell them to, at 16 weeks, at 32 weeks, because that's when we are able to see and look and really know what's going on and see some issues with the heart if there are some. Chest X-ray, heart cath, all of those. Treatment depends on how severe the signs and symptoms are. It's almost always corrected with surgery, and they'll just do a switch. They cut it, move it, and sew it back up together. It is considered a definitive repair. So once it's fixed, they don't have to worry about it the rest of their lives. It's done. So that's great, right? We still have issues with post-op care, education, and discharge instructions. But typically, once they fix it, they're good to go. But recognize that post-operatively we can have complications. We can have some bleeding, we can have some internal bleeding, we can have some issues. So we gotta be watching for blood pressure issues and all of those things with post-operative care. Total anomalous pulmonary venous connection, TAPVC. So, these are different types of TAPVC. You can see all kinds of issues here where we have issues. It's just a lot of issues. I don't know any other way to put it. Basically, the pulmonary blood flow returns to the heart through the right atrium instead of the left. Usually there's an ASD that mixes the blood, causing a cyanotic condition. There's usually right-sided hypertrophy and enlargement. Partial anomalous pulmonary venous return can also occur. We're going to look for a murmur, cyanosis, respiratory distress, lethargy, poor feeding, frequent respiratory infections, and signs of heart failure. This is diagnosed again through signs and symptoms, EKG, echocardiogram, chest X-ray, and heart cath. This may also be seen on the fetal ultrasound as well. They have to have surgery. Once they have surgery, they can have a full normal life. You do have to watch though for the restenosis that can happen with the pulmonic valve, some issues that you have with that, so you watch for the reoccurring stenosis. You teach about the possibility of that, post-op care, that kind of stuff. All right, I think we're gonna stop there because I show that it's 10:46, which means it's 4 minutes until everything shuts off. I did have a request for some more SurePath, things to be open for you to look at and go through some lessons and things like that. I can open them, I just didn't want there to be any confusion over what's an assignment, what's required, and what's not. So if you look at your calendar, the one that's assigned will be on the calendar, whereas the others won't be, you'll just be able to go in and see them. And I'll do that this afternoon. If you're having trouble understanding these anomalies and you're not sure about whether it is oxygenated, not oxygenated, or whatever, read through the different boxes in the book. If you still are having trouble, let me know. Ask questions on the discussion board, and I will do my very best to answer those questions.